Our learning objectives will be to understand the pathophysiology of type 1, the typical progression of type 1, explore the complexity of the pharmacologic and psychosocial treatment of type 1. We're going to learn the general concepts and supplement to the insulin lecture about daily insulin regimens for type 1 diabetes. Be familiar with sick day management. Understand how to screen, prevent, and treat hypoglycemia. That's both in conjunction with the hypoglycemia lecture. Know the risks for and the identification and early treatment of DKA. And then an overall general clinical plan for the routine care of someone with type 1 diabetes. So when we look at the epidemiology is where we'll start. Anywhere from 5 to 10% of people in the United States who have diabetes have type 1. If you lump LADA, latent autoimmune diabetes of the adult, with type 1, it's 10%. If you keep type 1 separate from LADA, it's 5%. That's about 3 million people have type 1 diabetes. It's equal between the genders, and it does seem to have a seasonal preference to winter and spring related to infections. In addition to that, about 15,000 adults are diagnosed every year with type 1 diabetes. And we believe that the rates of type 1 are increasing in adults and kids, not nearly as great as type 2, but they are going up in type 1. Now, even though there are many children diagnosed with type 1, the great majority of people with type 1 diabetes are actually adults because they continue to live into adulthood. And I'm happy to say that this generation is currently seeing the results of aggressive treatment of type 1 diabetes and are suspected to live a normal life expectancy. As we mentioned in the introductory lecture, we no longer use the term juvenile or immune-mediated. Type 1 diabetes is indeed an absolute deficiency of insulin due to an autoimmune attack of the beta cells. But for clarity's sake, we want to talk about type 1 diabetes. We know that there's peaks in childhood, and we used to think of this as a childhood disease. And you can see peaks within early childhood. But now we know that there is a second area of peak in middle-aged adults between the age of 35 and 50 called LADA, latent autoimmune diabetes of the adult. And occasionally you can see diabetes in those above the age of 50. Typically when someone presents above the age of 50, because of the significant other potential abnormalities such as pancreatitis and pancreatic cancer, you'll want to rule these out before you definitively diagnose type 1 diabetes in an adult above the age of 50. And as we mentioned in the introductory lecture, there's multiple types of type 1 diabetes. So type 1A is what most people think of. Type 1A is the classic autoimmune disease in which you have measurable autoantibodies and an autoimmune process that results in the absolute lack of insulin secretion. We'll talk a little bit more about that in the pathophysiology. This makes up the great majority of type 1. There is a type 1B though, and originally we thought maybe this was not known to be autoimmune because we didn't have known autoantibodies that were tied to that. However, with the relatively recent discovery, zinc transporter 8 autoantibodies, which are almost always positive in type 1B, we're now back to thinking that maybe they're slightly different immune processes, but this is still an autoimmune disease. And then finally, we know about latent autoimmune diabetes of the adult, or a slowly progressive form of type 1 diabetes that occurs in adults in middle age. So now we'll move to pathophysiology. We know that the pathophysiology of type 1 is rather complicated, and it requires multiple steps to occur, and each one of them have to work in tandem with each other. So we know that there's a genetic component that causes an immune dysregulation, and we know there has to be an environmental trigger that will turn on that genetic machinery to cause autoimmunity. And that immunity will attack potentially, say, the trigger, the virus, but it also has an abnormal response and will attack the beta cell and cause beta cell destruction and type 1 diabetes. And we're thinking about genetics. There does not appear to be a familial pattern to type 1 diabetes. We know that 90% of people with type 1 diabetes have no family history of type 1 diabetes. Um, and even if a person has type 1 diabetes, their child only has between a 6 and 11% of developing type 1 diabetes, or their brother or sister has only a 5% chance of having type 1. And even in identical twins who grow up in the same home, so potentially have the same genetics and the same environmental exposures, still have a less than 50% rate of penetrance and developing type 1. So we know that it's more complicated than just the genetic component itself. When we're considering the genetics, we know that MHC susceptibility is a big deal and that there are HLA types that are related or correlated to type 1 diabetes, and they even differ between different ethnicities. So HLA DR3 and DR4 are most closely tied to type 1 in Caucasians. DR7 most commonly associated in African Americans, DR9 in Japanese, and also there's a relationship with different single nucleotide polymorphisms tied to type 1. So when we look at different SNPs, or single nucleotide polymorphisms, you can see that the relative risk for type 1 diabetes has increased anywhere from 1.2 to almost 7 times greater with certain SNPs being present. And when we look at the action of those SNPs, the great majority of them are related to change in autoimmunity, although some are related to insulin secretion or ventral pancreas differentiation. What about the environmental factors in type 1? So what's most agreed upon is that there's a relationship between enterovirus exposure and type 1 diabetes in susceptible patients. Other factors are less agreed upon and can be quite controversial. There's a question of whether there's perinatal factors that are involved. The timing of immunizations, do they somehow relate to diabetes? One of the more prominent theories that is currently not being followed, but is there a discussion between cow's milk and timing of cow's milk in relation to type 1 diabetes? And some European countries have correlated the timing of exposure to cow's milk to the rates of type 1 diabetes in the country. Are there other environmental toxins, either in the food or in the environment, that we have not yet identified that puts us at risk for type 1? And certainly the current popular theory is, are there changes in the gut biome that put us at risk for type 1 diabetes? And my question will be, is from the studies we've seen so far, are these changes in the microbiome the cause of type 1 or the result of type 1? And I think these questions still need to be answered. So what's the mechanism for which viruses could induce type 1? And so, again, we're still not entirely clear. We probably don't think it's direct beta cell infection and death. It might be related to molecular mimicry. So is there something in the presenting aspect of the beta cell that looks similar to these viruses? Is there just an innocent bystander hypothesis going on? Or has our lack of exposure to pathogens in our early childhood from our sterile environment put us at risk for having an abnormal immune response? And again, all of these are still investigative, and we're not really sure at this point. So this is a graphic from Eisenbarth that's really been very helpful for us to kind of understand what's the progression or natural history of type 1 diabetes, particularly type 1A. And so if you start from the left, we assume that a person is born and they have 100% beta cell mass and function. So their pancreas is working, their beta cells are working. But we think they have a genetic predisposition because of a certain HLA typing. And again, that doesn't necessarily mean that you're going to go on to have type 1 diabetes, but it is one of the potential markers. Then you get this environmental trigger. The environmental trigger, let's say, is a virus infection that maybe everyone in the family is exposed to, but for whatever reason, due to your genetic makeup, you start to not only attack the virus, but you also attack your pancreatic beta cell. So you go through a period of time where you're initiating your immune response, but also an autoimmune response. And during that time, it's largely T cell mediated through CD4 and CD8, but you're also generating autoantibodies. These autoantibodies include GAD, glutamic acid decarboxylase 65 antibodies, islet cell antibodies, insulin autoantibodies. And these are markers of the disease. And at first, there may not be enough damage to reduce the ability to manage glucose, but at some point, there's enough injury to the beta cells that you actually start to get abnormal glucose response. And as you see the slope here, as you start to have declining beta cell mass, you're going to have declining beta cell function, and eventually you'll start to develop dysglycemia. Now, more often than not, patients are asymptomatic during this time, and because we don't routinely screen, particularly children, for glucose, we wouldn't necessarily find these people to have diabetes or prediabetes. But if this autoimmune destruction continues, and it doesn't continue in everyone, but if it continues, eventually there'll be 80 to 85% of the beta cells lost, and you'll be symptomatically presenting with diabetes. And so at that point, we believe that there's no turning back, that we can't revive enough beta cells to stop the onset of type 1 diabetes. So now we'll move to clinical presentation. And as we had talked about in the earlier slide, there's been a lot of work trying to find a way to reduce the progression to type 1. So we know that we can actually do genetic screening, but unfortunately genetic screening is not universal, and that you can be positive and not develop type 1 diabetes. 2, we also could do nationwide screening of autoantibodies, but unfortunately they also are not 100%. So we know that some people will not have these autoantibodies, and you'll learn shortly that some people with type 2 actually can have these autoantibodies. So even the presence of autoantibodies are not good enough. So the Juvenile Diabetes Research Foundation, ADA, recently came up with staging of diabetes. So you can see stage 1, 2, and 3. And the thought is that we should be staging diabetes type 1 so we can really focus our research efforts. Stage 1 diabetes type 1 is really focused on, we know that someone has the genetic predisposition, they may have had the environmental exposure, but they have normal glycemic control and normal beta cell mass. So really that would be a primary prevention of type 1 diabetes. Stage 2, you have the autoimmune attack, and you actually probably develop some dysglycemia, but you're not, frankly, presenting with diabetes. And this is really where the majority of the work has been to date. And then finally, stage 3 diabetes is when someone presents symptomatically with type 1 diabetes. So the most common clinical presentation for type 1 diabetes is the polys and weight loss: polyuria, polydipsia, and polyphagia, and weight loss. These patients are usually pretty sick. They often present in diabetic ketoacidosis, which we'll learn a little bit more about later, and often need to be hospitalized. Part of the presentation is nausea, vomiting, and abdominal pain, and often patients think they have the stomach flu, and they're often surprised when they find out they have diabetes. And as we will go into great length about, the initial education for the person and their family with type 1 diabetes is really, really important, and it allows for a smoother course of type 1. Now, if someone is a child and they present with polys and weight loss, I don't need autoantibodies every time. But there are going to be times where I'm unsure if they have type 1, or the times where I need to prove they have type 1 if I want to get some special treatment covered. So there are lab values that will help you to confirm the diagnosis of type 1. 85% of people with type 1 diabetes will have at least one of the following serologic markers. GAD autoantibodies, GAD65, are the most sensitive. You can also see islet cell antibodies and insulin antibodies. And then I had told you about zinc transporter antibodies. If they have more than one of these, there's no question of the diagnosis. They can have one and this not necessarily be clear about the diagnosis, but I would say that this is not a very common scenario, and use your autoantibodies to confirm your diagnosis of type 1. Now that's only part of the chemical equation. The other part is that you want to actually be able to measure the ability of the pancreas to secrete insulin. So we'll measure C-peptide and glucose. C-peptide, as you remember, when we look at insulin production, is the cleaving peptide in proinsulin, and it is cut off when the insulin molecule becomes active and released in vesicles. So C-peptide is a great way to measure endogenous insulin production. Anytime you order a C-peptide, though, you want to be able to order that C-peptide in conjunction with the glucose, because the glucose should be normal to elevated for the C-peptide to be present. Remember, in our hypoglycemia lecture, we know that you can suppress insulin secretion when you're hypoglycemic. So make sure that you have a normal to high glucose when you're ordering your C-peptide. And we covered this a little bit in the initial lecture, but I want to again highlight the differences between type 1 and type 2 for two reasons. One, as you'll hear from Dr. Hendricks, we now know that up to a third of children who are diagnosed with diabetes actually have type 2. And we know that there are as many adults diagnosed with type 1 diabetes as there are kids. And we really should be attuned to know when someone has type 1 and when they have type 2 because the treatment is so different. So these are kind of high-level features to help you sort this out. The most common presentation of type 1 diabetes is the polys and weight loss. And so this is really the defining feature of type 1. Occasionally you can see someone diagnosed early. Conversely, someone with type 2 diabetes is most commonly diagnosed asymptomatically by routine blood tests. So the symptoms are less dramatic with type 2. With type 1, more than 90% do not have a family history of diabetes, but they could have a family history of other autoimmune diseases. In contrast, people with type 2 diabetes usually have a very strong family history of type 2. Now, truncal obesity and body fat distribution used to be very helpful for us to separate type 1 and type 2. But now that 2/3 of our population is overweight or obese, this factor is less distinguishing because we're getting many overweight and obese people who are now being diagnosed with type 1. So while it can be sometimes helpful, it's less helpful than it's been in the past. In terms of other ways to distinguish between type 1 and type 2, the lipid panel, you remember that people with type 1 have an isolated single problem. They have autoimmunity to the beta cells and they don't secrete insulin. But we have no reason to believe that they have other metabolic abnormalities, and we expect their lipid panel to be normal. This is in comparison to type 2 diabetes, where dyslipidemia with low HDL and high triglycerides are characteristic, in many ways a defining feature of type 2 diabetes. So the lipid panels look different. We also know that the C-peptide levels should be different because they're low to absent in type 1 and normal to even high in type 2, particularly early in type 2. And then autoantibodies are most commonly present in type 1, and we really don't expect them to be present in type 2, but we've since learned that there is a small population that can have autoantibodies in type 2. And then you'll have to have other ways to confirm the diagnosis of whether they're type 1 or type 2, like the C-peptide. So here we've got a graphic showing us the rates of type 1 and type 2 diabetes in children at different age groups. And I want to highlight here that below the age of 10, if someone's diagnosed with diabetes, there's a very strong probability that that person is type 1, as noted in the dark blue. However, once the child starts to reach puberty, the distribution between type 1 and type 2 really starts to equal out. And in subpopulations like American Indians and non-Hispanic blacks, you'll actually see much higher levels of type 2 diabetes than type 1. And so this is really kind of comments on the significance of the hormones of puberty and how they contribute to insulin resistance. So as I mentioned earlier, diabetic ketoacidosis is the most common presentation for type 1 diabetes. Occasionally adults or children can be found with just hyperglycemia and not symptomatically, but that is still the minority of the patients. Many patients, once they've been diagnosed and started on insulin, can experience a honeymoon period. And the honeymoon period is important because you had autoimmune destruction and you had chronic hyperglycemia. The beta cells are only 15 to 20% are functioning, and many of them are stunned from glucose toxicity. Once you start to give exogenous insulin, you're going to decrease endogenous insulin secretion, which might turn down the autoimmune attack and might help restore some of the stunned beta cells. So you might get transient increase in insulin secretion, which means that you will have to decrease the insulin dose. Some families who are hoping for a miracle will say that maybe their diabetes is cured, maybe they won't need insulin, but I would really encourage you to strongly educate the families that type 1 diabetes cannot yet be cured and that the honeymoon period can be a normal component of type 1 diabetes and that they should still anticipate a lifetime of needing insulin. So some special features that we kind of focus on for managing type 1 diabetes. Certainly we want to make sure that we educate our patients about hypoglycemia. We know this is common. Anywhere from 2 episodes of hypoglycemia per week in type 1 diabetes, and even 1 severe hypoglycemic episode per year is common. And these you'll need to educate your patients about how to identify hypoglycemia, how to prevent it, as well as to treat it. Skills that the patients will need to help this will be to understand the action and duration of the insulins that they're taking, know what physiologic insulin administration looks like. They need to be consistent in their glucose monitoring, and you'll have to have some plan for how they're going to handle carbohydrates, whether that's carb consistency, which means they're having a set amount of carbs at every meal and every snack, or that they learn carb counting, where they can have freedom in their dosing of carbohydrates, but then they match their insulin dose match their carbohydrate intake, which is what I find most of my patients prefer. So as a provider, you want to make sure that you assess hypoglycemia for the patient and the family at every visit. You want to know how often it occurs, what happened when it occurred, is there a situational thing, or does there need to be an adjustment in treatment? What was the response at the time, and how has the person handled it since? As we talked about in the hypoglycemia lecture, you want to make sure that every patient has fast-acting carbohydrates present with them at all times, and that they know the rule of 15s as a treatment of mild hypoglycemia. Everybody with type 1 diabetes also should have glucagon. Glucagon is the EpiPen of type 1 diabetes and can be life-saving. And so you want to make sure that the patient and their family members know about the appropriate use of glucagon to help save their life. And then certainly we'll talk at the end of this lecture about how advanced insulin delivery can really reduce the rates of hypoglycemia. Next, you want to make sure that your patients with type 1 diabetes have a sick day management plan. This is really important because patients with type 1 diabetes are going to have the same illnesses that many other people will have, but it does require some vigilance in how you're going to handle your food and your insulin during that. So we work with our patients, and everyone has an individualized sick day plan. Usually that requires that they're going to do increased glucose monitoring, and sometimes it means they have to increase their insulin, sometimes they have to decrease. So for example, someone might have the stomach flu and not be able to keep anything down, and with prolonged fasting, they might actually have lower glucose readings, which means they'll have to reduce their insulin. Conversely, with many illnesses, the stress response from the illness will actually raise glucose, and they might actually have to increase, let's say, take doubling of their correction insulin. Or maybe they even have to increase their basal insulin if they're going to be sick for a couple of days. And then there should always be an exit strategy. So if they're following their sick day plan, we usually want to make sure they know when they need to get help. So for example, if someone has been following their sick day plan and their glucose continues to rise despite 2 efforts to take bolus insulin corrections, or if they're doing their sick day plan and they start to develop moderate to large ketones in their urine, or if they start to develop significant symptoms, we might ask them then to seek urgent or emergent care. And the main reason why we do this is we want to identify early and prevent, when possible, diabetic ketoacidosis. So diabetic ketoacidosis is the other end of the severity of problems with type 1 diabetes. Hypoglycemia is one end, hyperglycemia with diabetic ketoacidosis is the other. Most commonly, diabetic ketoacidosis is caused from insufficient insulin. And what happens then is that at the cellular level, you get ketotic and acidotic in combination with hyperglycemia. This should be considered a medical emergency, and again, it's due to an absolute insulin deficiency, and can largely be prevented with a good sick day management plan, early intervention, and if they start to get sick, getting in early for treatment makes it much better. Despite this, there still is a significant cause of morbidity and mortality in type 1 diabetes. So now we'll talk a little bit about some unique challenges to type 1. Um, Most people now know, with the prominence of diabetes, somebody with type 1 diabetes. Certainly we know a number of stars. So Nick Jonas would be one example. Halle Berry has type 1 diabetes. This is Mary Tyler Moore, who recently passed. And she was diagnosed with LADA, latent autoimmune diabetes of the adult. And this is a quote from her that I felt was really useful for healthcare providers to know. Both children and adults with diabetes, like me, who live with type 1 diabetes, need to be mathematicians, physicians, personal trainers, and dietitians all rolled into one. We need to be constantly factoring and adjusting, making frequent finger sticks to check our blood sugars, and giving ourselves multiple daily insulin injections just to stay alive. And I think that really is important to remember that the work in type 1 diabetes is substantial. And having good education and good planning can make this a little bit easier for people. It's always going to be a lot of work. But when you're treating someone with type 1 diabetes, please remember to be respectful and recognize the process, not just the product. So family dynamics can also be a challenge. Many times when a child is diagnosed with type 1 diabetes, there's overwhelming guilt within the family. Parents feel that somehow they've done something to be responsible for this child getting diabetes. And really the evidence doesn't support that. So what ends up happening is you may have parents who are overzealous and they become helicoptering parents that might be overprotective and really getting in the way of the normal maturation and development of that child, largely to try to compensate somehow for feeling guilty. This can affect not only the child, it can affect their siblings, it can affect the parents, and it's very common to see families split up after a child's been diagnosed with type 1 diabetes or other chronic diseases. Further, because of the complexity of having to be able to track and regulate carbohydrate intake, we actually can see an increase in eating disorders. The other problem that we see with that is that, let's say the child was initially thin, when they start taking insulin, most children will end up gaining weight. And so they don't necessarily like gaining weight or being different. And so it's very important that they make sure that the children and the family are getting the right support for healthy adjustment with this disease. And then we also know that having type 1 diabetes is an independent risk factor for increased risk of depression and or anxiety disorders, as well as eating disorders. And this is particularly true in our adolescents. We have a condition called diabulimia, where the children may use food intake or emission of insulin as an extension of an eating disorder, and sometimes just to be spiteful of their families or caregivers or parents. And then finally, we know that type 1 diabetes as an autoimmune disease makes them at risk for other autoimmune diseases, and they will be screened for those, and we'll talk a bit about that. So what about the treatment of type 1? And we'll talk about both the lifestyle treatment, self-management, as well as the insulin treatment. And I like to actually start with day one. So when someone is typically diagnosed in the hospital, and we'll just say for the sake it's a child, they're diagnosed and they're acutely sick. On day one, I want to stabilize the patient, and I really want to give very simple but very few messages to the family. And these are the things I think you need to communicate. Number one, that this is diabetes. If you know for sure it's type 1, you can communicate that. Sometimes we don't know. Two, that this is a lifelong disease, that this is not going to go away like a pneumonia or other infections. And then I really make every effort to make sure families understand that there's nothing that they could have done to cause this, and there's nothing that they could have done to prevent that. And as we learn to understand type 1 diabetes better, maybe that will change. But I think that we owe it to our patients and their families to free them of the guilt of thinking that somehow they did something to cause type 1. But that might be the only thing I educate the patients on that very first day. By day 2, the child and the family are feeling a little bit better. The child's no longer critically ill. They've been hydrated. Maybe their acidosis and ketosis have been normalized, or maybe it's improving. And they're maybe at a place now to start having a conversation. And they'll have a lot of questions. And I might start with just, what questions do you have? And if they don't have it, then I talk about some of these things. So why did diabetes occur, and why did it occur now? What is insulin, and why do they need to take insulin? And what does this mean for the rest of their life, for them and their family? And I think that these are things that are really heavy in their minds early on in the diagnosis. I can't overstate enough that inpatient, if this patient's been diagnosed inpatient, diabetes education is so critical to getting people off to a good start. If you're seeing them as an outpatient, make sure they get outpatient diabetes education. The education team is so critical to healthy management and having the best skill set possible to manage this. And the education team might look different. Sometimes it can be certified diabetes educators, sometimes it could be nurse educators, sometimes it's a specialty team. But whoever it is, you want to get them involved as soon as possible. This team typically will teach the patient how to do glucose monitoring, how to take insulin injections. These are actually 2 skills we want the person to be independent on before they leave the hospital. We want to make sure they get started on nutrition education, which will be a much longer process. And we want to help them to learn how to do some problem solving. So what to do when they're hyperglycemic, what to do when they're hypoglycemic. And then also to have kind of some clear delineation about what components of self-care are they responsible for at this time. Sometimes it can be the child being responsible for something and the parents others. Sometimes it can be the parents responsible for everything. But then also, when should they be calling for help? And this is really important because lots of times people will have questions they don't even know they're going to have until they get home. So for example, they get home and the child wants to have a snack at night, and this wasn't something they had at the hospital. How are they supposed to handle a snack? Or the child has a fever and they want to give them liquid Tylenol. How does liquid Tylenol affect the glucose? So you want to make sure that you address the simplest things first in the hospital, but also give them access to the education team or you once they get home, because they're going to have many more questions. When I look at treating a patient with type 1, I'm really trying to focus on a normal life and normal empowerment, so that people with type 1 can do all the things that someone without type 1 could do. And that we want to give timely education that allows them to take progressive increase in self-management control, but do this in a way that they can also learn from experience. Because sometimes you don't even know what questions come up until it comes up as a game time decision. I also want to highlight that diabetes education is not a one-time and done factor. Diabetes education is an ongoing component of diabetes care and should be repeated throughout someone's lifetime. So it might be that it's repeated at different times during developmental, so when they're a child versus a teenager, versus when they're a young adult or when they're planning to have a family. It might also need to occur when there's a change in responsibility. Maybe the parents are letting the child now manage the insulin regimen, and maybe the child knows how to dose insulin, maybe they don't, because maybe the parents have been doing it for them. We also want to know anytime there's a change in the medication regimen, it's a great time for diabetes education. And if there's been a change in health status, so if a complication's developed or if there's some other problem that might compound or get in the way of diabetes self-care, it's a great time to go back and involve a diabetes educator. So what are the skills that are needed? Certainly glucose monitoring is critically important. Insulin administration. Carb counting, I find in my patients with type 1 really do the best when they know how to carb count, make their insulin match their food. But insulin has to be matched with a number of things. So I think it's really important for you to appreciate that if you had type 1 diabetes and you're sitting down to dinner tonight, you're going to have to take a number of factors into account. What is your glucose before dinner? How are you feeling today? Are you sick in any way? Do you have a fever? What's going to be your physical activity that was before the meal or maybe after the meal? What's your current stress level? What's the amount of carbohydrates you're going to take? And what's the fat and protein content that might slow down your absorption of carbohydrates? What's your sensitivity to insulin? All of those factors need to be decided upon before you give an insulin dose. We want to make sure that people with type 1 diabetes can handle hyper and hypoglycemia. We want to make sure they know sick day management. And we want to make sure that they help train a circle of people around them to give them support when they need help, because rarely can someone do this entirely by themselves. We highlighted this just a little bit earlier. When it comes to nutrition for type 1 diabetes, they don't necessarily have to have a special diet. In fact, I find that most of my patients with type 1 have better adjustment when you give them freedom in their diet, but you make sure their insulin matches their life. So there's two ways to do this. One is you use carb consistency. A very common protocol that I learned was 30 grams of carbs at every meal, 15 grams of carbs at every snack, and then you can actually take a fixed dose of insulin if other variables are not changing. However, if you'd like to have variety in your life, you could use a carb ratio. So for every so many grams of carbs, say 15 grams of carbs, you'll need 1 unit of insulin. Then as long as you're conscious and logging your carb intake, you can make your insulin match your food. Even this is imperfect. We know that a slice of pizza and a piece of lasagna might have the same carb content, but might not have the same glycemic profile. And people will have to learn how to modify their carb ratios based on that, but also based on how their body responds. The American Association of Diabetes Educators has a really helpful tool called AADE7 for diabetes self-management. And if you're starting to work with your patient on this, I find that these are 7 key areas that you can focus on to help them to have good self-management skills. So that includes healthy eating, being active, doing glucose monitoring, taking medication, problem solving, reducing risk, and healthy coping. And this can be for any type of diabetes. So now we'll move to the comprehensive diabetes care plan. Typically when you see someone newly diagnosed, you're going to see them very frequently. But once they've settled in and they have good self-care skills, we find that most of our patients are seen every 3 months. This is more common than maybe some of the other diseases. Because there are so many factors that can involve titration of care, these regular visits really seem to help. Remember that your person with diabetes will have all the normal developmental and or age-appropriate screening exams, and that you want to not forget about overall self-care. And then you also want to plan for transitions in life, such as college, if they're going to start drinking alcohol, if they might be taking drugs. How does sex affect diabetes? And then certainly family planning. And then we'll have this, a lot of this we'll talk in the complications lecture. But some things that we want to do from the clinical side is we want to make sure we're reducing microvascular complications. We do that through diabetes foot exams, urine microalbumin assessments, and dilated eye exams. Often these exams are delayed in someone with type 1 diabetes by about 5 years because we believe that there is a grace period before we expect to see any of that. These same exams we would do actually at the diagnosis of type 2. We certainly still focus on cardiovascular risk reduction, the number one cause of death in people with diabetes, so that's including lipid screenings, use of statin, appropriate aspirin use. And then we also want to screen for other autoimmune conditions such as celiac disease. Everybody agrees that you should be checked at least once. There's some controversy about whether repeated screening is necessary for celiac. And then we generally recommend annual thyroid screening for people with type 1 diabetes as well, because up to a third will have autoimmune thyroid disease. So what are the treatment goals for type 1 diabetes? I'm going to give you the generalities, but tell you that we still always do individualization of our treatments. It's currently recommended that children with type 1 diabetes be treated to a hemoglobin A1C goal of 7.5. This is a little bit higher than we have in our adults, mostly because children are growing, they have widely variable schedules, and they can be somewhat unpredictable. And so we find that having a little bit looser glucose goal allows for maximum function in life and reduction of hypoglycemia. The default A1C goal in adults is 7%, And we actually have a higher A1C goal of 8 to 8.5% if it's an older adult above the age of 65 or someone with comorbidities. And saying that, these might be where we start, but we might adjust that goal up or down based upon patient level factors such as engagement, motivation, access to resources, and other factors. And I'll show that to you in the type 2 diabetes lecture. And then, as I mentioned earlier, we do these other screenings, but we can delay them by 5 years because we don't expect them to occur early in disease. So what about medication for type 1? The cornerstone of treatment of type 1 is replacing the deficient hormone, insulin. As you probably saw this same graph in the insulin lecture, this is what normal insulin, physiologic insulin looks like without someone with type 1 diabetes. You can actually trace this baseline across, and there's always a little bit of insulin secretion. There's a little bit of a diurnal pattern where you get a little bit less overnight where you're most sensitive to your insulin, maybe a little bit more first thing in the morning, between 3 and 8 a.m. This is when the hormones that allow you to wake up, including cortisol and growth hormone, are secreted. And then you see a very rapid first phase insulin release and a slower second phase insulin release with each meal. So if you look at these 3 meals listed here, breakfast looks like it would be relatively high in carbohydrates, but maybe a little bit less mixed nutrients, where maybe lunch was a very strongly mixed nutrient meal where a little bit less of a spike of insulin was needed for the carbs, and then with the mixed nutrients, your second phase insulin release was a little bit more prolonged. So we want to try to mimic that the best we can. Now, we'll never be able to mimic it entirely. Insulin that is secreted from our body goes from the beta cell of the pancreas, sent to vesicles, and it goes to the portal vein to the liver. And approximately 40 to 60% of that insulin is used by the liver initially and then distributed to the rest of the body, what's left. So the insulin focus is the liver first, body second. When we administer insulin from outside the body, it gets absorbed and it goes to the entire body first. So we actually over-basalize the insulin, or over-insulinize the body rather, and we under-insulinize the liver. And that's just one of the current imperfections of exogenous insulin. But when we give insulin, we want to try to have a basal component, here in green, something that covers the kind of ongoing metabolic needs of our basic metabolic rate. And we want to have a mealtime insulin component that covers the meals. Now, we've not been able to mimic first and second phase insulin release with subcutaneous injections of insulin. So we have to take the imperfections of insulin, as noted here, and to try to at least get close to what physiologic insulin looks like. So many people with type 1 diabetes will be taking both a basal insulin, which is what they need for required basal metabolic needs. This generally suppresses hepatic glucose production at night and between meals and tends to be relatively constant. We usually will use a weight-based dose, and it's typically dosed 1 time per day, or if you're using an insulin pump, there's a release per hour. And then we have a prandial insulin. And so this is an insulin that's been intended to be given at mealtime. And it's really got, physiologic insulin has that first phase release and second phase release. We've not been able to reproduce that. So we really are giving just 1 dose of insulin to cover the meal. And the intention of prandial insulin is to give enough insulin to match the carbohydrates in that meal, not to match the glucose. We'll talk about when it matches the glucose, but prandial insulin is intended to match the carbohydrates of the meal. Now we'll go to correction insulin. We know that life is imperfect. Sometimes we eat the entire meal. Sometimes we eat part of the meal. Sometimes we go back to seconds. Sometimes we miscalculate the carbohydrates we're going to eat. Or sometimes we have stress. Maybe I'm trying to eat while I'm giving a lecture and I'm having additional stress. Correction insulin, which some people have deemed sliding scale insulin, which I encourage you not to use that term, is the amount of insulin that has to be added or subtracted to the prandial dose to normalize a glucose to get it to goal. This should really be based upon a person's sensitivity to insulin, not just the glucose that you find. because someone with type 1 diabetes will have a very different insulin sensitivity than someone with type 2. This is something that should be figured out and or calculated, and it takes a fair amount of practice. So when I'm giving correction insulin at a meal, I'm adding the correction dose or subtracting if I need to raise the glucose. This correction insulin is being paired with the prandial insulin. It could be the same insulin, I just have two components of that dose. And so the way that we calculate that, we're using this part of the correction insulin to normalize the blood sugar, is I take the actual glucose, I subtract from where I want it to be, the target glucose, and then I divide that by the person's individual sensitivity to insulin. You'll get to do this in the lab, but I'll just give you an example. If my current glucose is 250 milligrams per deciliter, and I want my glucose to be 150, I'm going to have to correct it above and beyond for whatever insulin I'm going to take for the food I'm going to eat. Now, in this case, I've already figured out that my insulin sensitivity is 50. That's something that would have to be figured out, meaning that 1 unit of insulin will drop my sugar 50 points. So if I'm at 250, I need to be at 150. That's a 100-point drop I need to get. If my sensitivity is 50, I'm going to need to take 2 additional units of insulin on top of my mealtime dose to normalize my glucose. So this is something that's very important, and it's quite a bit safer than doing sliding scale insulin. And we'll get to practice this in the lab. So we know that in type 1 diabetes, it requires active insulin management. It means you're going to do 4 or more finger sticks glucoses every day, 4 or more insulin injections every day. And then you're going to have to do active adjustment of insulin, including this correction insulin that I just talked about. That's a lot of work. And for some people, they prefer to use an insulin pump or continuous glucose monitor. So I hope that it's incredibly clear to you that the work for type 1 diabetes is complex and time-consuming. And I want to highlight to you how much that's the case. So we did a study where we surveyed diabetes educators across the country. And we asked them, how long do you think it takes to do all the things you're supposed to do in terms of what you educate patients with type 1 that they should be doing to manage their diabetes? What are those things and how long will it take? So here's a child. And I'll use child as the prototype for type 1. So we have a child who's been diagnosed with type 1, who's had it for at least a year, so they're not learning new skills. They have these skills already. They're on intensive multi-dose insulin therapy. They're checking their sugars at least 4 times a day, and they're taking 4 injections per day, because I think it's key for you to know the management strategy to know how much work it will take. And then these are the lists that diabetes educators recommend that are important for self-care. And you can see that the list is quite long. Home glucose monitoring, record keeping, insulin administration, foot care, oral care, problem solving, getting medical supplies, scheduling appointments, parental visits for schools for hyper or hypoglycemia, meal planning at home, meal planning at school, shopping for food, preparing meals, exercise, physical activity, stress management, support groups. That's a lot of work. Now, granted, some of these things are probably true for any child, but some are really truly unique for type 1 diabetes. So when we asked the diabetes educators to estimate how much time per day this is going to take, you can see that the diabetes-specific tasks located on the left there accounted for more than 2 hours per day, every day, on top of their daily routines. And if you looked at some of those more general common needs, such as meal planning, shopping, physical activity, meals for school, you could see it got another 3 hours. So more than 5 hours per day was needed to do optimal management of type 1 diabetes. And I think this is really important for us to appreciate as we start to work with our patients with type 1 diabetes. This is a really daunting task, and it can be done, but it requires understanding and partnership. So the last couple things. I think it's very important for you to have a dynamic relationship with your patient and know who's in charge at each step and who's responsible for what. We know that problem areas in diabetes include the transition from childhood to adolescence, where there's kind of a starting of independence of self-care. There's a big problem with the emerging adult, So when a teenager goes off to, say, college or goes off to their first job and live in their own apartment, often the normal social structure and supports for diabetes are now gone. They have to go find their own doctor, they have to find their own support system, and often they don't seek care for a long period of time. It's also a great time for rebellion. So if the parents have been managing their diabetes, they may want to wash their hands of the responsibility of diabetes and maybe do less self-care for a while. And this is, of course, problematic because that not only hurts them now, but also in the future. Many people with type 1 diabetes keep their disease very close to the heart. They don't share with their friends and family that they have type 1 or their significant others. And this is actually quite important. Diabetes can be largely self-managed, but it does require a small village. And making sure that your loved ones, your significant others, your roommates know about your disease and help you can problem solve is very important. And then finally, family planning is important. Even though I told you that it is not typically passed through families, women who get pregnant actually can have substantial higher risk pregnancies if they're not well controlled. So planning for a pregnancy, doing aggressive insulin, even more aggressive insulin management during pregnancy can really help them improve outcomes. And then certainly there is a lot of math and potential technology involved in managing type 1. And not everyone is math adept. And so you'll have to work with your patients at where they're at and what their skills sets are so they can have the best self-management skills. So finally, technology. Technology in type 1 diabetes has really been a boon. While we continue to work to try to cure type 1 diabetes, technology has made it a little bit easier. I'll routinely tell my patients that I'll do whatever I can to make it as easy as possible for them to manage their diabetes, not that it'll ever be easy. So we know technology in diabetes improves patient safety, improves the accuracy and precision of insulin dosing, can reduce hypoglycemia, and it's very strongly preferred by patients with type 1 diabetes once they've used technology that they want to continue to use it to help manage their diabetes. And that includes things like insulin pumps, sensors, and calculation devices. I went back, I'm sorry for 1 second. The other thing is that it's important to know that patients care a lot about if they have to wear these pumps, they wear them all the time. They're things that can be a real distraction. They don't want to have things attached to their body. It might identify them as having diabetes. So the more that they can individualize it, the better. So you can see in the bottom right, this person has had different covers for their pumps. It allows them to individualize it a little bit. In the bottom middle, you can see that this pump also communicates with the iPhone or the smartphone. And so they can use their phone to help do dosing of their pump. So many people are on their phone all the time. This might even be more discreet. And some of the pumps even allow for remote visualization and or monitoring. So some of these pumps, not only can you see your glucose readings on your smartphone, but you can also have your spouse see it. So while they're at work, they could actually see what's happening to your glucose. And that sometimes can be a good thing. Sometimes that may not be a good thing, but it does increase the potential for safety. Sorry for the switch in this slide. Now I'm ready to go to this slide. So what's the benefit of active management? We've talked a lot about active management, and we certainly have talked about the risk of hypoglycemia. Well, the best example of active management being beneficial in type 1 diabetes is the Diabetes Complication and Control Trial, as well as the Epidemiologic Diabetes Intervention Trial, so DCCT and EDIC. And so this was a trial in type 1 diabetes where they had active insulin management with 4 shots per day or an insulin pump for about 6.5 years. And then they followed these patients. And at the end of the initial study, there was substantial benefit in reduction in microvascular complications, but not macrovascular complications. What I show you here is the 2 longer-term follow-ups. So at 17 years after the study, remember they only had 6.5 years average intervention, there was a 76% reduction in retinopathy, a non-significant 41% reduction in macrovascular events, but a 2 to 3-fold increase in hypoglycemia. So we actually found that we have to kind of maybe individualize who we're going to intensively control. But now it's been 30 years since that study's been done, and I think it's really important to show the legacy effects of early intensive glucose control. So patients who were in the study 30 years ago and had intensive glucose control now get the following benefits: a 46% reduction in retinopathy, a 61% reduction in proteinuria, and now a significant 57% reduction in heart attacks, strokes, and cardiovascular death. And so this is something that really is a testament to the benefit of long-term diabetes control, intensive diabetes control. So what's the future of type 1 treatment? So there's currently ongoing investigations about the potential benefit of some of the type 2 therapies used for type 1. This includes metformin, maybe improving insulin sensitivity, because exogenous insulin can actually decrease insulin sensitivity. The use of GLP-1 receptor agonists to lower glucose and maybe reduce weight gain from insulin. We certainly have seen benefit off-label of using SGLT2 inhibitors in type 1 diabetes, but there comes with the complication of euglycemic diabetic ketoacidosis, which has made it probably not likely to be FDA approved. And what has waxed and waned in popularity over time is pancreatic replacement therapies. So certainly one of the treatments for type 1 diabetes is pancreatic transplant or potentially an islet cell transplant. These are currently still considered mostly investigative for many of our patients because we don't have a lot of long-term studies to show benefit. We're certainly looking at alternative insulin delivery systems, including taking stem cell related therapies, and we continue to move our pumps closer to closed loop insulin pumps. These are all promising ways that we hope to make managing type 1 diabetes easier, safer, and more effective. So in summary, type 1 diabetes is an autoimmune disease that targets the beta cells and results in absolute insulin deficiency. As of today, type 1 diabetes cannot be prevented, nor can be caused. It can occur at any age. We talked about as many adults are getting it as kids, and it requires substantial patient and family education and a lifetime of judicious management and treatment. Problems can occur at life transitions, and as a healthcare provider, our job is to be there and available to help with these. And we know that active management improves quality and quantity of life. And certainly technology has been very helpful in the management of type 1. So what I have here is just a couple of recommended readings. Actually, only 2 of them are here. I'll add the third. Certainly, we'll add the American Diabetes Association Standards of Care. We'll also add the abridged Standards of Care, and I'll give you the links. There is a Managing Type 1 Diabetes Through the Lifespan reading, and then Diabetes Care for Emerging Adults that really talks about that critical period going from adolescence to adulthood and how it's an important time to manage type 1 diabetes. Thank you for your attention, and I look forward to seeing you in lab.